Dear all, welcome to the next session on the NPTEL course on local anesthesia and dentistry. Local anesthetic is the key important topic for any procedures done in dentistry, and painless procedures are very much required for a successful treatment. I am Dr. Jimson, former principal of a dental college and a professor and head of the Department of Oral Maxillofacial Surgery, and right now I am the president of the Association of Oral Maxillofacial Surgeons of India, Tamil Nadu Puducherry branch, and also an executive committee member of the Asian Association of Oral Maxillofacial Surgeons. Today's topic is going to be on mandibular local anesthetic techniques. Mandibular local anesthetic techniques is essential for effective dental procedures involving the lower jaw. And this course will explore various techniques, including the inferior alveolar nerve block, the buccal nerve block, and the mental nerve block. And we will cover the anatomy, just an overview, which is relevant to each technique, their indications, their contraindications, and the potential complications as well. And you would like to master these techniques, which will enhance the patient comfort and the procedural efficacy, making it a very important skill for dental professionals. And join us as we learn about the principles and practical applications of mandibular anesthesia. And the mandibular nerve, which is the third division of the trigeminal nerve, plays a very, very important role in the sensory and motor innervation of the lower jaw. The mandibular nerve, as you know, emerges from the trigeminal ganglion, which is located in the middle cranial fossa, and it exits through the foramen ovale. I would like to highlight the branches of the mandibular nerve, and we have two branches, the sensory and the motor branches. The sensory branches include the auriculotemporal nerve, which supplies the skin of the temporal region and part of the external ear. The buccal nerve or the long buccal nerve, which provides sensation to the buccal mucosa and gingiva. The lingual nerve, which supplies the anterior 2/3 of the tongue and floor of the mouth. And the inferior alveolar nerve, which innervates the lower teeth, the mental region, and chin. The motor branches innervates the muscles of mastication, including the masseter temporalis and the pterygoid muscles. So what are the clinical relevance? Understanding this anatomy of the mandibular nerve is very, very important for effective local anesthesia techniques, particularly for procedures involving the lower jaw. As you can see here in the image on the right, the area is anesthetized by giving the various techniques, the long buccal nerve, which is shaded in yellow, the inferior alveolar nerve block, which is shaded in green, and the incisive or the mental nerve block, which is shaded in blue. And what are the armamentarium required? As you all are aware, you'll need a small bore needle, which can be from 24, 25 or up to 30 gauge, or a small syringe, which usually most of us use a 2 to 3 ml syringe. It can go up to 5 ml, but then 2 to 3 will be ideal. And the local anesthesia with or without adrenaline, as you know, with adrenaline, without adrenaline has got various indications, gloves, sterile gloves, and the topical anesthesia if it is an intraoral approach. And what are the various other techniques? We have both the direct and the indirect techniques, the inferior alveolar nerve block, the buccal nerve, the Gaugates technique, the Vasarani Akinosi, mental nerve block, incisive nerve block, and the other extraoral techniques, the direct techniques. And the indirect techniques will include the Fisher 1, 2, 3 and other subtimental techniques like intraosseous and the intrapulpal. And intraosseous, they have the periodontal ligament, intraseptal, and the intraosseous technique. Now we'll discuss about the various intraoral techniques, which will include the infiltration technique, a field block, and the nerve block. So what is the infiltration anesthesia, which is commonly used in the maxillary maxilla, and not so often used in the mandible because of the quality of bone. You have cancellous bone in the maxilla and dense cortical bone in the mandible, and that is precisely the reason why we prefer nerve block over infiltration in the mandible. And infiltration anesthesia involves injecting the local anesthetic directly into the tissues surrounding the operative site, and the mechanism by which it works is that it diffuses into the nearby nerve fibers, thereby blocking the transmission of pain signals. And it can be used in minor surgical procedures or extraction of a single tooth, but not the mandibular molar, but in the anterior mandible, and can be used for superficial dental treatments like restorations, or it is ideal for soft tissue and small procedures involving a small area. And the advantages will be a quick onset of action, minimal complications, and it can be suitable for use in poor access to the nerve. And the limitations, as you know, it is not very effective for large areas or deeper tissues, and high doses may be required to achieve desired effects. Next, we'll see about the field block anesthesia, which involves the injecting the anesthetic around the surgical area but not directly into it, and the goal is to anesthetize the nerves supplying a broader region. The blocks the nerve pathways proximal to the surgical site, preventing the transmission of pain signals. And the indications for the field block anesthesia will include treatment of larger areas like soft tissue surgeries or extraction of multiple teeth. Again, as I mentioned, can be in the anterior mandible. And it is also often used in minor oral surgical procedures. The advantages of the field block will include the larger area of anesthesia compared to infiltration, and also useful for areas that require more extensive tissue coverage. And it also has its own limitations. It is got a slower onset of compared to infiltration, requires more skill for precise administration, and require more anesthetic. So what are the indications? As I already mentioned, the success rate in the 6 anterior teeth for infiltration anesthesia is highly effective. And the anatomic considerations is because of the greater number of nutrient canals, and these canals allow the anesthetic to reach the terminal branches of the nerve supplying the anterior teeth, increasing the success rate. And what are the nerves anesthetized? The terminal branches of the nerve, and in this region you have the mandibular, the incisive nerve, or the mental nerve. And the technique involves injecting local anesthetic into the tissue above the periosteum, allowing the effective anesthesia of the large targeted tooth and surrounding area. The needle should be positioned parallel to the long axis of the tooth being anesthetized, and this ensures optimal delivery of the anesthetic and minimizes the discomfort. The site of injection is at the mucobuccal fold, and the injection site is located where the buccal mucosa meets the alveolar mucosa. And the site is typically found at the height of the mucobuccal fold near the apex of the tooth being treated. So now let us see the nerve block, and first you will see what is a nerve block. And the nerve block anesthesia involves injecting the anesthetic near a specific nerve or a nerve trunk, blocking sensation in a wider area. And what is the mechanism? And the local anesthetic is deposited close to the main trunk, affecting a large area supplied by that nerve. Now, what are the indications? Procedures like wisdom tooth extraction or other jaw surgeries or multiple extractions, or even a single tooth extraction if it is a mandibular molar. And it is again ideal for procedures in both hard and soft tissues, and the advantages or over the infiltration or field block is huge, and it provides profound anesthesia over a wide region and reduces the need for multiple injections, like a field block. And it reduces, and the use, it can be used for a long duration surgeries. And it also comes with some limitations, and you require a precise knowledge of the anatomy and of the local anatomy to get a highly successful nerve block technique. And first let us discuss about the mental nerve block. And this is usually done for procedures involving the buccal soft tissue anterior to the first molars. They can be used for restoration of anterior teeth, soft tissue surgeries in the anterior mandible region, and any other periodontal procedures affecting the buccal tissue. It provides anesthesia to the lower lip and the chin, making it particularly useful in cases where the soft tissue manipulation is necessary. And I have already mentioned the indications. And the nerves anesthetized, as you know, is the mental nerve. And what are the contraindications? If there is an acute inflammation or an infection at the injection site, as you know, because of the pH of local anesthetic solution, the injection will not work. So in such cases, the inferior alveolar nerve block will have to be given instead of the mental nerve block. And the injection site will be at the mucobuccal fold or near the mental foramen between the first and second premolar. This again, an operator position or the patient position is of paramount importance unless there is an operator is at a comfortable position, and not only the operator, if the patient is also not at a comfortable position for the operator, and the patient should also be in a comfortable position so that you have more confidence in performing any procedure for that matter. Likewise, here again, for a right or left mental nerve block, a right-handed administrator should sit comfortably or stand, whatever is comfortable for the operator. These days, most of us practice sitting dentistry, and hence I mention that you can sit comfortably in front of the patient so that the syringe may be placed into the mouth below the patient's line of sight. That is again because patients can get intimidated at the sight of a syringe with a needle, and particularly so if it is a cartridge syringe as well. And what are the various anesthetics? The lower lip, the gingiva, and the mucobuccal fold anterior to the mental foramen. And the anatomical landmarks will include the mandibular bicuspids, the first and second premolars, where the mental foramen is located. That is the very important anatomical landmark. So now we'll see the technique as to how the procedure is done. Retract the lower lip and gently pull the lower lip outward to expose the injection site, and the needle should be parallel to the long axis of the mandibular premolars at the site of approximately 5 to 6 millimeters. And use a small gauge needle, as I've already mentioned, and the thumb placement, it should be placed below the mental foramen. You should palpate near the first and second molar to guide the injection to ensure the correct needle positioning. And you follow this technique, and this approach will allow the precise delivery of anesthesia near the mental nerve for a good success rate. Not all the patients will like to see the site of needle again and again. That creates more apprehension among the patients. So the proper technique done the first time will enhance patient cooperation as well. And there are a few tips that you have to take note of. Avoid intraforaminal injection by withdrawing the needle if the patient reports paresthesia. So, and aspirate. before the injection, because it will ensure that you are not in the blood vessel to avoid the vascular injection. And inject 0.6 ml of local anesthetic slowly into the targeted area over 20 seconds. That is again a very important point to note. It has to be a slow injection for a painless procedure, and also to avoid systemic complications. Next, we'll see about the long buccal nerve and what are the indications used for surgery of the mandibular buccal mucosa, and also is an adjunct to the inferior alveolar nerve block for procedures involving the posterior mandible. And as you know, the buccal branch of the anterior division of the mandibular nerve is the target area and also the nerve to be anesthetized. And the buccal mucosa and the mucoperiosteum of the mandibular molars will be the areas anesthetized. And precisely the technique, position the patient with the mouth open wide to expose the posterior mandible, and the technique, the needle is inserted into the buccal mucosa distal to the third molar, or just it can be just buccal to the mandibular molars, the first or second or third molars, and using a small gauge needle penetrate the mucosa at an angle parallel to the occlusal plane and insert the needle depth to 2 to 4 millimeters. It's like infiltration procedure. And again, for any procedure that you do, you need to aspirate and inject to ensure that you are not in a blood vessel, and slowly inject 0.2 to 0.3 or 0.4 mm of local anesthetic. And there is an alternative technique to the technique that I just explained, which is injecting into the retromolar triangle or a retromolar triangular approach. And if the third molar is absent or axis is restricted, you can use the retromolar triangle as an insertion site. And briefly into what a retromolar triangular is all about. It is a triangular area posterior to the last molar, and it is bordered by the internal oblique ridge and the pterygomandibular raphe. And where do you inject? Where does the needle get inserted? Insert the needle at the highest point of the triangle, just below the last erupted molar, and again insert at a shallow depth of around 2 to 4 millimeters to target the buccal nerve. Again, don't forget to aspirate and then inject, as with the primary technique as previously described, to rule out the intravascular injection, and then inject again 0.3 to 0.5 ml of the anesthetic solution. Next is a very, very important, most often used inferior alveolar nerve block for any procedure, surgical procedure or extraction, which can be a simple extraction or a minor surgical procedure, an open view technique or a wisdom tooth removal. The most often technique used is the direct or indirect inferior alveolar nerve block. So, what are the nerves anesthetized? You anesthetize the inferior alveolar nerve along with the lingual nerve, and as described earlier, you need to, if you are doing a procedure in the posterior mandible, you need to get your long buccal nerve as well anesthetized. So, these are the nerves that are anesthetized in an inferior alveolar nerve block. And what are the indications? The primary indications will include any procedure, operative procedure involving the mandibular teeth in one half of the jaw, because a block on the left or right side will anesthetize the teeth from the midline, from the central incisor to the third molar on one side. And also They are effective for root canal treatment on the or any other procedure, and it provides anesthesia for surgeries or procedures involving the buccal and the lingual mucosa of the lower jaw. Also, ensures numbness in the for any procedure in the flora of the mouth or soft tissue procedures or any biopsies. And it also anesthetizes the tongue, the anterior two-thirds of the tongue via the lingual nerve, which is anesthetized along the inferior alveolar nerve block, allowing for procedures involving the tongue, such as, again, can be any procedure like biopsy or any excision of any lesion in the tongue. And this block provides widespread anesthesia covering a large portion of the mandible, soft tissues, and tongue, making it highly effective for extensive dental and surgical procedures of the lower jaw. This has to be reiterated again and again and suggests the importance of this injection technique. And the anatomical landmarks will include the mucobuccal fold, the external oblique ridge, the retromolar triangle, the internal oblique ridge, the pterygomandibular raphe, and the pterygomandibular space. So I'm not going into the detail of each and every anatomical landmark, but then you should know the importance of each landmark. Why is the mucobuccal fold important? It is important for orienting the initial injection point and guiding the needle parallel to the occlusal plane. About the external oblique ridge, it helps in identifying the posterior extent of the mandible, locating the retromolar triangle. And retromolar triangle is a key landmark for positioning the needle tip during the block, ensuring correct trajectory towards the pterygomandibular raphe. And next comes the internal oblique ridge, which helps guide the placement of the needle as it lies medially to the target injection site. And the pterygomandibular raphe is palpated to guide the needle insertion for the inferior alveolar nerve block, and the needle is placed just lateral to the pterygomandibular raphe. Next is the most important anatomical landmark that everybody should know, and it is a very often asked question either in the final year or during internship or in the postgraduate training. Pterygomandibular space. Why is it important? Because that is precisely where you are going to deposit the local anesthetic solution, and it is located between the medial surface of the mandible. I'll come to that later in the next couple of slides about the boundaries of the pterygomandibular space. And these landmarks ensure proper needle placement and the likelihood of success of an inferior, not only the success and the safe inferior alveolar nerve block while minimizing complications are high. And now again, as I mentioned earlier, during the mental nerve block, the operator position is of paramount importance, and for the right-handed dentist, the 10 o'clock position, and for the right side rather, and for the left side, it is in front of the patient, or 8 o'clock position. Again, the patient should be placed, should be seated at a very comfortable position for the patient as well as for the operator as well, and turn the patient slightly towards you to expose the most posterior aspect of the mandible, because if the mouth opening is restricted, then we have other techniques like the Vazirani Akinocytec, which I will be discussing later in my presentation. So for direct inferior nerve block or an indirect technique, or for that matter the Gauguet's technique, different techniques, proper mouth opening is very, very important. And the and with the mouth open, and the body of the mandible is also parallel to the floor. You palpate the key landmarks starting from the mucobuccal fold to the external oblique ridge and the retromolar triangle. And the height of insertion of the needle will be approximately 8 to 10 mm above the occlusal plane, which will correspond to the deepest point of the pterygomandibular raphe, ensuring that the needle enters the pterygomandibular space effectively. And the anterior posterior distance should be 2/3 of the distance between the index finger placed in the coronoid notch and the pterygomandibular raphe. That is again very, very important, that 2/3 of the needle is inside. I will explain what if there is an anterior contact or two posterior contact, or you don't come in contact with bone at all in the subsequent slides. But now for the basics, you should understand that 2/3 of the needle should be inside the soft tissue, and move very gently till you come in contact with the bone. And once you come in contact with the bone, you should have a very good tactile feedback. You should feel that you're in contact with the bone, and you're close to the mandibular foramen. That comes with the experience. And once you're experienced enough, you will definitely know where you are, where the needle is because as you know, it's a blind procedure. You'll not be able to visualize where the needle is, but then the tactile feel, you will know where exactly your needle is going to be. And from the opposite side, premolar, bisecting the finger, place the what do you call the needle. And the final position of the needle will be exactly near the lingula of the mandibular foramen, which is the bony projection at the entrance of the inferior alveolar nerve into the mandibular foramen. And once you come in contact, slightly withdraw the needle, because depositing the solution near the bone will be painful. Slightly withdraw, rotate, so that you are not into the vessel. Aspirate. That is again a very, very important point. And then inject. Why do you want to aspirate? As I already explained in my presentation, to avoid intravenous deposition of the local anesthetic solution. Either it may be with adrenaline or without adrenaline. As you know, the local anesthetic is a vasodilator, but if you add adrenaline, it is a vasoconstrictor, which will have other systemic complications, which will be explained by my other colleagues in the subsequent lectures. So the proper positioning at the site is very crucial for achieving the successful anesthesia. And also, what is the volume of solution that you will deposit? 1.2 to 1.5 ml of local anesthetic solution. Again, over a period of, a point to note is that over a period of 60 seconds or 1 minute, a slow rate of injection is of great importance for again two reasons. One, for painless anesthesia. Next is to prevent or reduce the percentage of systemic complications. Slow rate of anesthesia is again very, very important. And as I mentioned earlier, just a quick run through of the boundaries of the pterygomandibular space and the contents. The anteriorly by the pterygomandibular raphe, posteriorly by the parotid gland, and medially by the medial pterygoid muscle, laterally by the ascending ramus of the mandible, superiorly by the two heads of the lateral pterygoid, and inferiorly by the attachment of the medial pterygoid muscle. What if there are anatomic variations, which is not very common, but then 15 to 20% of the patients, individuals rather, can have anatomic variations. So what if it's a child? It's not the same as giving a block in an adult. So in a child who's 4 years or younger, the mandibular foramen is typically located below the plane of occlusion. This means that the foramen is situated lower in relation to the occlusal surface of the teeth, which can affect the technique and the depth of the local anesthesia during the dental procedures. And also, a point to note is that as the permanent first molars erupt, the mandibular foramen gradually shifts superiorly within the ramus, and this upward movement alters the position of the foramen and is an important consideration for dental surgeons when performing inferior alveolar nerve block in children, as it impacts the ideal injection and the technique. And understanding these variations is essential for effective anesthetic administration and ensuring safety and comfort of pediatric patients. And as I indicated before, what if the needle comes into contact with the bone immediately or shortly after the insertion? What you have to do is to swing the barrel of the needle towards the central incisor. Again, reposition the needle slightly to ensure that it is correctly aimed towards the pterygomandibular space. Hope I am clear. Reposition, shift to the near the incisor. Again, readjust the position of the needle slightly to ensure that it is correctly aimed towards the pterygomandibular space. Or the next scenario can be if the bone is not, if you are not in contact with the bone at all. That means it is the needle, even after having gone beyond the 2/3 distance, you are still not in contact with the bone. So again, what you do is swing the barrel of the syringe posteriorly and reposition it and angulate it to the depth to redirect towards the mandibular foramen. Again, adjust the syringe where the needle can be redirected towards the mandibular foramen and within the pterygomandibular space. Mind you, if you are not in contact with the bone, if you are not near the lingual or the mandibular foramen, and if you are depositing the solution posteriorly, if you are not in contact with bone, your local anesthetic, your inferior alveolar nerve block is not going to work. So that is a typical landmark. And these corrective measures help accommodate the anatomical variations and enhance the accuracy of the inferior alveolar nerve block technique, ensuring effective anesthesia during the dental procedures that you do. And the advantages, as we all know, that it is got a wide area of anesthesia and provides the comprehensive anesthesia for a large region, including the mandibular teeth, soft tissue, and the lower lip. But then it comes with some disadvantages as well. Wide area of anesthesia. Why is it that I have mentioned that that it is a disadvantage? It's just because that you want to extract a single tooth or a small soft tissue procedure, but then no other option but then to give a the one half of your jaw is numb, anesthetized. And this can be an advantage, but then it leads to unnecessary anesthesia of non-target areas, causing prolonged numbness and discomfort. And sometimes it can be instances of insufficient anesthesia. Another important point to note is the positive aspiration, 10 to 15%. That's a risk of accidentally injecting into a blood vessel, which can occur in about 10 to 15%, potentially leading to some systemic complications, and hence negative aspiration is very, very important before you deposit the solution. And lingual and lower lip anesthesia may be undesirable for some procedures, hence it is mentioned as a disadvantage. And partial anesthesia in case if there is a bifid mandibular canal. And you should know about the advantages, disadvantages, so that you can pick and choose the anesthetic technique accordingly, whatever is required for the particular patient. So what are the causes of failure of the nerve block? And as I discussed a couple of slides earlier, if the anesthetic is deposited too low on the ramus, it may not be adequately reach the inferior nerve, leading to insufficient anesthesia. And also, if the deposition of anesthetic is too far anteriorly in the ramus, thereby ineffectively targeting the mandibular foramen, resulting in inadequate numbness or of the intended area, and accessory innervation to the mandibular teeth. It most often happens when you are doing a procedure on the mandibular the incisors. There can be a collateral supply from the nerve supply from the other the opposite side. And also, not only that, the accessory sensor innervation can also be from the cervical accessory nerve or the mylohyoid nerve, which can provide additional sensation to the mandibular teeth tissues, leading to incomplete anesthesia. Some of us will know that you have given a perfect block, you check for anesthesia and it is working perfectly all right. Still some patients complain of sensation, and that is precisely because of this reason, because of accessory sensory innervation from the cervical accessory or the mylohyoid nerve. And other incomplete pulpal anesthesia can lead to patients experiencing pain or discomfort during the procedure due to inflamed pulpal tissue, or I will discuss that again later. And the presence of additional innervations may contribute to the incomplete anesthesia. Complications, again, my colleague Dr. Shoban will be discussing about the local complications, and just to name a few, if it is a high injection, numbness of the ear when the auriculotemplar nerve is anesthetized. Again, at trismus, if it is injected to the lateral pterygoid, toxicity, injection toxicity due to injection into the pterygoid plexus of veins. And in case if it is a low injection, the injection into the medial pterygoid can lead to trismus, and injection into the posterior facial vein can lead to similar toxicity issues, as anesthetic may enter the venous circulation. And what if there is a deep injection complication? It can lead to paralysis of the facial nerve, and nothing to worry, it is just a transient if you are injecting into the substance of the parotid gland, and it can lead to transient facial paralysis and a loss of motor function in the muscles of facial expression. And also, you can accidentally puncture a blood vessel during injection, and it can lead to hematoma formation, causing swelling and discomfort in that area. And why do you want to know these complications? When you know the complications, you will be well prepared to avoid these complications.